you for partnering with us. I did want to let people know about a couple of events that we have at the hospital. So next month, we will be doing another Grey's Anatomy on May 28th, and that's going to be about stroke awareness and stroke prevention. And you sign up same way that you did for this one. Also, tomorrow, if you are available in person at the library, we are having a variety of representatives from LMH. We're having palliative care nurses, social workers, a lawyer who works with the hospital to talk about advanced directives, things that you need to have in terms of paperwork, who needs that at the hospital, who do you need to get it to, all of that really important information. So that is tomorrow from 10:30 to 11:30. And then this weekend, we will be at the farmers market. So if you happen to stop by the farmers market, please look for the LMH Health booth and stop by and check us out. With that, I'm going to jump to the event of the evening. So we have with us today Dr. James Kim. He earned his undergraduate degree at the City College of the City University of New York and his medical degree from the College of Medicine at Sunny Health Science Center at Syracuse. He completed his residency through the Brown University program in internal medicine and his fellowship at Long Island Jewish Medical Center. Dr. Kim is board certified in gastroenterology and is an active member of the American College of Gastroenterology, the American Gastroenterologists Association, and the American Society for Gastrointestinal Endoscopy. So with that, I'm going to turn it over to Dr. Kim.
Hi, everyone. This is, believe it or not, first time I'm doing a Zoom talk. I've always done, I've done a lot of talk in front of audience, but Zoom is something new, so bear with me today. The topic is going to be on bloating, gas, and distension. I hope you guys can hear me pretty well.
We're good.
I had a lot of talks done with the fellows and residents in the past regarding this, but I was more interested in giving you guys an update as to what you need to know. What's exciting right now in terms of research and what's going on in the university centers and tertiary centers, and so you get an idea. You hear about all this, about microbiota and FMT and a small intestinal bacterial overgrowth and IBS, and all these terms are thrown around, but I'm going to try to maybe hopefully simplify a little bit for you today and make it more interesting. The objective is to talk about as bloating, distension, talk about some of the causes, epidemiology, and maybe even discuss some diagnostic and treatment options. Again, giving a talk to lay audience with these slides, I'm going to try to simplify my terminology so it'll be easy for you to understand. Bloating is a sensation of increased, the key word is the sensation of increased abdominal pressure, fullness, and gas. It is a sensation, and you don't always have to see a visible distension of your belly. A lot of people also complain of distension, which is a visible increase in abdominal girth. You can feel bloated, but you may not experience the distension. But having said that, majority of patients will experience bloating with distension, up to 75%. These symptoms are often accompanied by excessive belching, or we call it eructation, and flatulence. Flatulence, as you know, is passing gas. However, not all bloated patients pass gas, as you know. So there's a slightly different, you might say, mechanism behind how you feel bloated and when you would pass gas, okay? And I'm sure you guys will have millions of questions regarding this. Let's see the next slide. So epidemiology of bloating is that about 30% of patients complain of constant or chronic bloating in United States. So it's a very common symptom. Matter of fact, it's the most common functional GI symptom in United States and probably all around the world. And like I mentioned before, bloating and distension occurs together in about 76% of patients, but 24% of patients with bloating will never experience distension. And I'll explain to you why that is. Based on this national study done by Dr. Che and University of Michigan, they recruited almost 90,000 just general population, general American adults in United States. And they just, I think it was a telephone survey, and they found that about 14% of them, or 1 out of 7 patients, experienced bloating just within the week prior to the survey. And during the survey, they found that the bloating was more common among certain demographics like women, Latin Americans, and people who are aged less than 60. So generally, 60 being young, less than 60 complained of more bloating than the more elderly population. They also found some comorbidities, other accompanying conditions like celiac disease and IBS, Crohn's disease, ulcerative colitis, are found to be fairly common when you take a careful history from these population. Other accompanying symptoms of GI symptoms include abdominal pain. So if you feel bloated, you're often experience abdominal pain. There's going to be some excess gas, complaints of gas filling up in their belly. Trapped gas is another term they use. And constipation was very common. Interestingly, about 60% of patients never seek medical attention. So they don't think that it's a medical emergency, that the fact that they feel bloated, because it's such a common symptom. What are the causes of bloating? Common things like people with gastroparesis, motility disorders, colonic pseudo-obstruction, patients who complain of chronic constipation for the past 20 years or so. These patients will often have bloating. Other causes like conditions that cause excess gas formation, like malabsorption, like celiac disease, for example. People had extensive intestinal surgeries. Pancreatic insufficiencies, things like that can also cause excess gas. Increased bacterial fermentation, meaning you ingest something like lactose or too much fructose, carbohydrates, starches that are difficult for you to digest, but you eat a little too much of it, and then bacterial fermentation occurs and excess gas forms. Aerophagia is interesting. It's an ingestion of air. There's gastric form of aerophagia and then supragastric aerophagia, meaning some of these conditions are psychological, meaning you ingest air and you burp it out as to get some relief, but it's the psychological, it's not coming from within the stomach. Not an uncommon condition. We see them quite often in the GI clinic area. Altered sensation or visceral hypersensitivity is a very common symptom associated with IBS, irritable bowel syndrome, kind of like having post-traumatic stress syndrome of the gut. So when they're stressed, instead of having, let's say, back pain or headaches, it goes to their gut. So they feel more pain, more bloating, more nausea, more diarrhea, more constipation when they're under stress. That's called the visceral hypersensitivity. There's a condition, this is a new condition called abdominal phrenic dyssynergia. I want to go over that with you. It's a fairly common condition where when you eat a lot of fiber in your diet, or you eat a lot of dairy products, for example, we get bloated. And normally, physiologically, you'll have normal visceral somatic reflex where your diaphragm relaxes and accommodates the gas, and it goes up into your thoracic cavity, to your chest. So your belly generally doesn't get pushed out too much. And that's the normal reflex. That's why we don't walk around like we're 9 months pregnant all the time, generally, even after eating a couple of slices of pizza. But for people with this abdominal phrenic dyssynergia, as you can see, the diaphragm does not relax very well. It contracts or it goes into spasm, where it actually descends instead of rising and accommodating the gas in your abdominal cavity. So what happens is your abdominal muscles that normally are contracting normally, and it stays put, has to relax to accommodate the pressure. So all these pressures applied to the abdominal wall, and muscles have to relax. Now you may look like you're 9 months pregnant. We've seen this, and I'm sure you see this in some of your family members and your friends when they eat certain high fiber foods or dairy products. For a few hours at least, they look like they're quite bloated and distended. And this is a fairly new phenomenon. There are many causes of bloating, in food, obviously, medications, GLP-1, the Ozempics and Mounjaros, things like that, that diabetics and people who are overweight take nowadays to try to lose weight, often slows down your gut, and they feel bloated a lot. And nausea is a very common side effect of that. Opioids are a very common cause of abdominal bloating and nausea. We're going to talk briefly about this SIBO, or small intestinal bacterial overgrowth, later on. There's pelvic floor dysfunction here, which can cause chronic constipation and difficulty with bowel movements. Abnormal bacterial flora can also do that. And we talked about the visceral hypersensitivity, having overactive, oversensitive gut and sensation can also cause bloating. A brief word about prebiotics and FODMAP, just to let you know that prebiotics are basically fiber that feeds or is a nutrition for the probiotics or normal bacterial flora. Okay, that's the difference between probiotics and prebiotics. Probiotics are normal bacterial flora that you can ingest by yogurt and taking supplemental tablets and so forth. Prebiotics are not the bacteria itself, but nutrition for the bacteria, and is usually fiber. However, not all fiber are prebiotics, okay? And not all FODMAPs are prebiotics. Some of the FODMAPs are prebiotics, and a lot of them are not. So it's very complicated. But let's talk about FODMAP, because a lot of people have questions about FODMAP. Just to tell you, there's a whole bunch of foods that you can enjoy and still be on a low FODMAP diet. And there are a whole bunch of foods that you have to avoid as well. So it becomes very complicated. And a lot of people ask, do I have to stay on this for the rest of my life? And the answer is no. Low FODMAP diet is meant to be tried for 8 to 12 weeks. And then you're supposed to gradually reincorporate some of these things, the FODMAP containing foods, to figure out which bothers you, which causes the bloating, and which causes indigestion, and so forth. So you don't have to avoid all of these foods, only the ones that causes active GI symptoms, okay? That's the purpose of this slide. It's not for you to go through every one of them, just to tell you that the purpose of this is not for you to remain on lifelong low FODMAP diet. Now, what is the low FODMAP diet good for? Let's go over that. I mean, what is the problem? Why would the IBS patients or functional bowel patients need to go on a low FODMAP diet? It's because FODMAP has been shown and proven to cause a lot of side effects in patients with IBS and functional abdominal pain and visceral hypersensitivity. First problem is the osmotic effect. So osmotic effect means it draws fluid and causes bacterial fermentation, and then it causes gas to form, and so forth. The other thing that the FODMAPs result in is what they call high concentration of short-chain fatty acids, SCFAs. These are basically a product of bacterial fermentation of starches and complex carbs that we cannot digest. And for some reason, based on the very numerous literature and studies, IBS patients do very bad with FODMAP diets. They have a lot of bloating, a lot of gas, a lot of nausea, constipation, diarrhea, you name it, all these symptoms. So when they tried low FODMAP diet in IBS patients consistently, and a lot of studies have shown tremendous amount of benefit. Again, the purpose of low FODMAP diet is not for them to remain on it for the rest of their life.
Doctor, can I interrupt just one
Yeah.
second?
Sure.
Can you actually define what FODMAP means or what it stands for?
Oh, yeah.
It's kind of
Sorry.
confusing.
Low
Sorry.
FODMAP diet. The FODMAP stands for fermentable oligo, di, and monosaccharides and polyols. Okay, that's the term that they use, and it's basically very complex groups of carbohydrates and starches and so forth. Okay, and fiber-containing foods, and the lists are very extensive. But all the studies they've done with low FODMAP diet and IBS has shown significant, statistically very significant benefit in these patients. So that's what I wanted to talk about with the low FODMAP diet. What about functional GI disorders? What conditions cause bloating, basically? And IBS is extremely commonly associated with bloating and gas and distension. Okay, we all know that. Whether it's constipation predominant or diarrhea predominant, they all experience some degree of this. Obviously more common in constipation predominant IBS patients. In patients with chronic idiopathic constipation, I'm going to tell you what the difference is in a second. More than 90% of them experience abdominal bloating and distension. Functional dyspepsia is basically having an irritable bowel syndrome of your stomach and the upper intestine. IBS is more of symptoms down below in your colon and distal intestine. You can think of it that way. And they present with indigestion, bloating, fullness, nausea, things like that. These patients also experience bloating up to 80% of patients. Very, very common. Gastroparesis, which is neuropathy, autonomic neuropathy, or sluggishness of the gastric contractions you see in, for example, diabetics a lot. They also experience bloating up to 70% of patients. So now, what's the difference between IBS-C and chronic constipation? All you need to know is that you have to have significant abdominal pain associated with your constipation. Okay, so the constipation part of it is the same. If the patient complains to you only about constipation, I've been chronically constipated for past 5 or 6 years, and I have to take laxatives almost every day to have a bowel movement, you cannot tell whether that's IBS constipation or chronic constipation. But if the patient says, yeah, I always have this pain and cramping and spasms before or during or after my bowel movements, and the pain is somewhat relieved when the bowel movement occurs, that's more IBS, okay? So which means to tell you that a lot of constipated patients don't complain of abdominal pain. They just want to have a bowel movement, okay? All right. There are a few different, I don't want to dwell on this too much, but there are a few different types of constipation. One is chronic, everyday idiopathic constipation. There's something called slow colonic transit constipation. There's opioid-induced constipation, medication-induced. We talked about GLP-1, the Ozempics and things like that. Pelvic floor dysfunction can also cause constipation. But pelvic floor dysfunction patients tend not to respond as well to laxatives or colonic stimulants. But some of them do. So that's why we have to try them on medicines first before offering them other modalities, just like such as pelvic floor physical therapy, okay, which is highly effective. Now, there are a few tests that we do for constipation, SITS marker study, where you swallow the SITS markers. That helps diagnose the different types of constipation. Smart pill is no longer available. They're taking it off the market. anorectal manometry, balloon expulsion test, dephagography, which is an X-ray, actual X-ray of you having a bowel movement, okay? These are extremely helpful in diagnosing pelvic floor dysfunction. And we perform these not uncommonly in our GI clinic. Not within our clinic, we send them down to the centers of excellence like KU and other hospitals who have these modalities to do these tests. Bristol Stool Form Scale, BSFS we call it, is very helpful in diagnosing, or you might say following patients with IBS-C, the constipation, IBS-D, diarrhea predominant. And basically, what's important is that constipation predominant patients will have Bristol scale of 1 to 2, lumpy, hard stools like the 1 and 2. Or if you have IBS-D, then you will have very soft, semi-formed loose stools or watery diarrhea. Okay, and that's how this Bristol Stool Form Scale is helpful. And I'm sure when you go to GI clinic, any GI clinic, whether it's a nurse practitioner or GI doctors, will ask you to look at this chart, and they're going to ask you to categorize your bowel movements. Okay, there are many treatments available for many great treatments available for constipation. 3 of my favorite are linaclotide or Linzess, available in 3 forms. Amitiza or lubiprostone, which is also available in 3 forms, and plicanotide, which is a Trulance. Those 3 are my favorite, and all 3 are very effective. The only reason why I prefer the Linzess is because it's a once-a-day dosing, and they're available in three different types of dosing. And if it's too strong, they're going to have a lot of diarrhea. Then I just reduce the dose down to the lower dose. Even if that's too strong, then I ask them to take it 3 times a week instead of taking it every day. So it's very convenient, highly effective, minimal side effects. Prucalopride is one word about that. It's also called Motegrity. The good thing about that is it has a stimulatory effect in constipated patients, but also has stimulatory effect in patients with gastroparesis. It also speeds up your stomach. So I do use this quite a bit in diabetic gastroparetic patients with pretty good success. The only problem is if it's not FDA approved for diabetic gastroparesis. It's only the FDA approved for chronic constipation. And that's the only drawback, okay? There are other medications that we use for opioid-induced constipation as well. What about physical activity? They did a lot of study on this in the past on chronic constipation patients 20 or 30 years ago, and they didn't have consistent benefit. So physical therapy was not considered one of the major modalities of treatment of chronic constipation or even IBS. But now more studies are coming out, meta-analysis and randomized controls trials are coming out that consistent physical activity definitely improves IBS symptoms. And I'm sure it's not just the physiological thing or mechanical thing. It actually improves the mood and sense of well-being and all that. That improves all the other aspects of IBS as well. Stress reduction, anxiety, depression, and all those are improving. One interesting thing is osteopathic manipulative technique. I call it acupressure. The certain acupressure massage of your belly and your hands, your feet, has shown to a certain degree to improve the motility of your gut and colonic transit and so forth. And this is a very exciting time, and all these research are going on right now. SIBO is small intestinal bacterial overgrowth. The only reason why I mention it at this time is because it is one of the causes of abdominal bloating, discomfort, pain, nausea, altered bowel habits, and all that. So it's one of those things that we do have to rule out. And basically, to make the long story short, small intestinal mucosa should not have a whole lot of bacteria in it. Usually it's less than 10 to the 4th power of amount of organisms or bacteria can live in the small bowel, but more than that is not healthy for you. Obviously, once you go closer to the colon, where colon has a lot of bacteria living in there, once you get closer to the colon, then the bacterial count will go up dramatically, 10 to the 9th even. That's normal. But you don't want to have bacterial count greater than 10 to the 4th in the small intestine. If that happens, then you can have all kinds of GI side effects. Normally, our gastric acid, bile formation, proteolytic enzymes coming from the pancreas, immunoglobulin A, ileocecal valve, all these things or factors are barrier from bacteria from colonizing or growing into the small bowel from the colon. And obviously, anything that negatively affects those factors, whether you had a bowel surgery that removes the ileocecal valve, you don't have a barrier, or you take a lot of PPI to reduce the acid, and so forth, may negatively affect your small bowel bacterial flora. Okay. I guess I have to keep track. These are the different causes of small intestinal bacterial overgrowth, which we're not going to go into in detail. There's a breath testing for small intestinal bacterial overgrowth, which uses lactulose and glucose. To make the long story short, we don't use lactulose very often because it has very high false positive rate. It's not as accurate. Glucose is better, but it does have some increased false negative rate. But this is the most common test that we perform because it's non-invasive, and we do get a lot of information. Gold standard test is, believe it or not, is very invasive endoscopic jejunal or small intestinal aspirate. You aspirate the fluid juice from the intestine, and you have to culture it to see how much bacteria grows in it. It's a gold standard test, but only very few centers in the United States have the capability of doing that. In interpreting the test, basically, is you have to have more than 20 parts per million elevation from the baseline of the hydrogen level within the 90-minute period. And I think that's all we need to know about that. Just a word about IBS with SIBO. There was a lot of research coming out saying that there are patients, certain percentage of patients with IBS who develop small intestinal bacterial overgrowth, and they're hard to distinguish between the two. So SIBO is being mislabeled as IBS, and IBS is being mislabeled as SIBO, and so forth. So they did a research on this, and some research has shown up to 60% of patients with IBS-D, or diarrhea predominant IBS, may have SIBO. But this is an older study from 2012, but there are many studies that came out after that. Doesn't show that high of a rate of SIBO, maybe more like up to 30 to 40% perhaps, but not up to 60%. And these patients have to be treated with antibiotics such as rifaximin. Why is rifaximin so popular? We use this all the time in GI clinic is because it's a non-absorbable antibiotic. So it doesn't get absorbed into your systemic system. It doesn't go into your blood. Therefore, the side effects are minimal. They only stay within your GI tract, and it kills off the unnecessary bacteria or harmful bacteria in the colon and the intestine as well. Highly effective. But it's an expensive medication. If the insurance doesn't cover it, I have used Augmentin, which is penicillin, ciprofloxacin, doxycycline. I have used that in the past with some success as well. There is something called methane predominant SIBO. Just one word about that is there is a bacteria, well, it's what they call archaea, which is not a bacteria, but something very similar to bacteria that lives in our gut, can generate excess amounts of methane. Now, what happens if there's an overgrowth of this archaea with more methane or high concentrated methane production? Then what happens is you develop bloating and constipation. And the archaea, specific archaea that they identify is called Methanobrevibacter smithii. That's the one that is the major contributing agent to the methane overproduction in our gut. Not everybody has it. Some people have it, and this can be also detected on our breath test. And if that's the case, then they also get treated with the rifaximin. Because we're talking about bacteria and microflora and all that, I think there's some clarification we need about fecal microbiota transplant. What is that? You're transplanting somebody else's stool, either by mouth by taking pills, or by doing a colonoscopy and putting the normal bacterial flora into the right side of your colon. And it's very exciting because this FMT has been very successful in patients with Clostridium difficile infections. Now, they changed the term to Clostridioides difficile infection, especially the recurrent bouts of this infection. FMT has been highly successful. Some studies have shown up to 95% efficacy, although I'll show you the meta-analysis of many different studies. If you collect them all together, you're looking at about 75%, but still 75% is excellent. Just the concept that you're not taking any more potent antibiotics, you're not taking any chemotherapy, and yet just putting somebody else's stool products into your system cures C. difficile infection up to 75%. That's really revolutionary, I would say, in my opinion. So what about FMT for IBS? This is interesting because IBS is so common. Why don't we just do fecal microbiota transplant in IBS patients? They've done that. They've done several studies on it. But basically, what I want to tell you is that the studies are quite heterogeneous and no consistent clinical benefit was noted on these studies in IBS. So IBS is a lot more complicated than just giving more normal bacterial flora or just taking tons of probiotics. Doesn't just cure the problem. There's many other aspects to that. This is the FMT IBS meta-analysis. You see all these trials. This one's 7 trials, and anything greater than 1 is beneficial. Anything less than 1 in this graph on the right is negative benefit, doesn't help. And you can see how heterogeneous it is. And so far, I would say FMT has not been approved for IBS. What about C. difficile, Clostridioides difficile infection? It's a gram-positive, anaerobe, spore-forming bacteria. Is 3% of patients, 3% of the population are asymptomatic carriers, but it is the #1 cause of antibiotic-associated diarrhea in the United States, especially in the hospital setting. It's caused by taking antibiotics, having inflammatory bowel disease like ulcerative colitis, Crohn's disease, anything that damages your colon, damages your intestine, causes inflammation or ulcerations of your bowel, becomes a setup for C. difficile infection, okay? So how does the fecal microbiota transplant or FMT for C. difficile infection, how does it work? So if you have a normal bacterial flora on the left, C. difficile has real difficulty colonizing and going in and invading into your colon. But when you take an antibiotics and you kill off your normal bacterial flora, and as the middle slide shows you, then the C. difficile say, hey, this is my chance. And they go in and invade the intestine, the colon, and then infection occurs. And you can get very sick from that. So you take the vancomycin, which is a highly effective antibiotic to treat C. difficile infection, and almost 90% effective in killing off C. diff. But what's the problem with that? The problem is when you give vancomycin, you're also killing off other good bacteria again. So you never get a chance. You keep treating with vancomycin over and over again. Yes, you can treat the C. diff, but you can never restore your normal bacterial flora back to what it was to the left until you give fecal microbiota transplant, FMT. This is why this is highly effective, and we can achieve very consistent benefit of up to 70 to 80% of patients. We won't dwell on this too much, but I just want to say Bacteroides and Firmicutes, these are type of bacteria. If they are running too low or they're not in consistent amounts in your colon, it triggers much more higher incidence of C. difficile infection, okay? Just to let you know, that's how important our normal bacterial flora is. in protecting us from invasive organisms. Okay. Let's go to the next slide. Again, this is the slide that shows you all these meta-analysis looking at many different trials of FMT or fecal microbiota transplant in patients with recurrent C. difficile infection. You can see up to 78% or 72% very consistent benefit when you transplant them. And some patients may require more than one transplant. Just single transplant may not work, and you may have to do second or third to achieve this number, but it still is achievable. Just one word that because I mentioned about inflammatory bowel disease in C. difficile infection, having inflammatory bowel disease, just to let you know, causes dysbiosis or disturbance in your normal bacterial flora of the colon. And this is a setup, pretty much. It's an opportunity for the C. difficile infection to grow in your colon when you have ulcers and inflammations and all that going on. That's the problem. It's a vicious cycle. So when that happens, the C. difficile infection occurs very commonly in inflammatory bowel disease patients. And then the C. diff itself aggravates the underlying colitis. So their inflammatory bowel disease gets worse. And so this is a vicious cycle. And these patients benefit tremendously from FMT, fecal microbiota transplant. Okay, that's why I wanted to show you this. Matter of fact, if a patient with ulcerative colitis comes to the hospital emergency department with diarrhea, abdominal pain, and cramping, we don't put them on antibiotics. We don't put them on steroids, which is the treatment for colitis. We know they're having a colitis flare-up. First thing we do in emergency department is we check for C. difficile infection. That's the #1 priority because it's so common. Okay. Just a word about bile salts and bile acids. Having the normal bacterial flora helps maintain normal levels of the secondary bile acids called lithocolate and deoxycholates. What does that mean? That means that the primary bile acids, the chenodeoxycholate and cholates, has to be converted to the secondary bile acids in the colon in order to fight off the C. diff. And it requires a normal bacterial flora to achieve that. So if you don't have enough secondary bile acids, your risk of having C. difficile infection goes up dramatically. So if you're wondering how does FMT always help? How does the bacteria help? It helps through the bile acid metabolism as well. Okay. What about FMT in your ulcerative colitis patients? Doing a fecal microbiota transplant in ulcerative colitis patients. Promising is what I want to tell you. So more and more data are coming out showing that it may even control the colitis, prevent the C. diff infection, but also control the colitis. So we're not there yet, but they're making a lot of progress in doing a fecal transplant for ulcerative colitis without using steroids and biologic agents and so forth. And hopefully we'll get there. What about liver disease with FMT or microbiota alterations? Just one word about primary sclerosing cholangitis. The reason why I mentioned this is because there's no treatment for it. There's no cure. And you can develop scarring of the bile ducts that sometimes can lead to cholangiocarcinoma, causes cancer and strictures. But there's no medicine for it. Steroid doesn't work, biologic don't work. But they're working on some in vivo studies to show if maybe giving FMT or improving the microbiota, bacterial flora of the colon or intestine may help reverse this disease. We're not there yet. They're working on it. Alcoholic hepatitis. A lot of people die from alcoholic liver disease, cirrhosis, alcoholic hepatitis. Turns out our bacterial flora has a lot to do with it. And if you give them good bacteria and get rid of the bad bacteria, you may actually improve their survival. And because the mortality is very high in patients with alcoholic hepatitis with liver cirrhosis, already have existing liver cirrhosis from alcoholism. Again, a lot of research is going on right now with this, and it's exciting time. Who would have known giving stool products to someone with liver disease, alcoholic liver disease, may improve their survival. We're not there yet. We're still working on it, and a lot of research is going on right now. What about checking microbiome for colon cancer screening? Not instead of just checking the hemoccult test for blood, or fecal immunoglobulin test, or Cologuard test, which is the test for you might say mutations in the cells that may suggest you may have precancerous polyps, or checking for colon cancer. Other than that, there's some studies are coming out that says maybe checking the microbiome, bacterial flora may help. This study showed that bacteria called Fusobacterium was associated with increased risk for colon cancer. And the Fusobacterium is a bacteria that causes periodontitis. It's an oral pathogen, oral bacteria. And we ingest them, and if it's too high, they accumulate too much in your intestine and the colon, it actually increases risk for colon cancer. So they're working on figuring out how to detect them, diagnosing them, how to treat them. Obviously, it's a long-term treatment. It's not a one-time treatment. It's about improving the bacterial flora to prevent colon cancer. Okay, so that's about it with that. Let's go back to breath testing. There's breath tests for lactose, there's breath tests for fructose, there's breath tests for sucrose. It'll tell you if you're lactose intolerant, you're fructose intolerant, you're sucrose intolerant. All these can be tested by breath test. And why? Because I would say about 5 to 10% of patients with IBS, chronic diarrhea, abdominal pain, bloating issues, do have these conditions, and they go undiagnosed. Now, for example, lactose intolerance is an easy one. If you don't even have to do the breath test. If you go on a 100% lactose-free diet for about 3 months, or you take the lactate enzyme tablet they sell any pharmacy before eating any dairy products for about 3 months, your bloating, your gas, discomfort, diarrhea, nausea, all that will improve almost 100% if you're lactose intolerant, because that's the only reason why you're having these problems. Believe it or not, I had an 80-year-old patient came to me to the clinic about 6 months ago, and she was told one time she was lactose intolerant, but she never been tested for it. She never went on a lactose-free diet. And she suffered from diarrhea and bloating and gas for almost 20 years. She came to see me, and I said, why don't we try full lactose-free diet? Why don't we try lactose-free diet or lactase enzymes? She did that for 3 to 4 months and come back and said, I feel 99% better, doctor. So it seems like an easy one, but unless you actually test it, you cannot find out. The same thing for fructose intolerance and sucrose intolerance are more rare, but those can also be tested. And one classic example, which is becoming popular now, is because now we have tests for it. We even have treatment for them. It's called sucrase isomaltase deficiency, which is also called sucrose intolerance. So we can't digest the sucrose in our diet. And it turns out about 30%, 35% of IBS patients have this, but they go on living without being diagnosed or being treated for it. And there's a simple test for that and treatment as well. So if suspected, I think this test should be done and treatment should be offered for that. That's it in regards to the management or diagnosing and management of IBS and bloating, gas, distension, and so forth. Well, I think time is good. We still have 10 minutes, so maybe I'll accept some questions from all of you.
Mute here. If we're ready for questions, while some people are typing those in, I have a couple I want to throw out to you.
Sure.
If we older folks watch TV, we see a gazillion commercials about probiotics.
Yes.
So if your body is balanced and if your gut is in good shape, is taking a bunch of probiotics because everybody says they're wonderful can it become a bad thing because you've imbalanced your body?
Good question. I think probiotics, generally speaking, will not be harmful. I consider that a kind of like a nutritional or vitamin supplement. It may have benefit, but I would only take it if you're otherwise healthy, you're not taking any steroids or any kind of immunosuppressants, you're not undergoing chemotherapy, you had extensive bowel surgery, something that may jeopardize or cause potential damage to the intestinal lining or colon, then taking a whole lot of probiotics, I don't think makes any sense. But if you're otherwise healthy, you're not immunocompromised, you're not on any chemotherapy, you don't have any major abdominal surgeries done, probiotics may be beneficial in many different aspects. For example, IBS and patients with mild inflammatory bowel disease, the studies have shown that the patients feel better when they take the probiotics, especially functional diarrhea patients. What is a functional diarrhea? Is they have chronic intermittent diarrhea, may not be every single day. They have it for a few weeks, and then they don't have it for a while, and then it comes back again. That's what's called functional diarrhea. We don't have a good explanation why they have it. These patients, I can honestly say, maybe about half of them, when they take the probiotics consistently, they get some relief of their diarrhea. So this has been presented in many different meetings and presentations, and a lot of experts agree that you cannot ignore it. It has some benefits. We just haven't figured out why. Now, the main reason why we haven't figured out why is because probiotics are not FDA controlled. Okay, gotcha. Probiotics are considered a nutritional supplement. It's not medication. Therefore, FDA doesn't control it. So they don't control what concentration goes in there, what variety of probiotics goes into each bottle. They can label it any way they want, and they can sell it anywhere, any possible way. As long as it doesn't cause any harm, it's available to you. But the problem is that when you take it, one probiotics is not the same as the next probiotics. Each company makes it differently, and it contains different kind of bacterial flora. That's the problem. But there's some studies that came out, something called VSL probiotics, VSL, and they've done some studies on that, and they've gotten more consistent clinical benefit using VSL type of probiotics. You can buy them. You can buy, they may be a little bit more expensive, but you can buy them. And it supposedly contain certain bacterial flora like lactobacillus, bifidobacteria, things like that in there in high concentrations, shown to be more effective in IBS patients and inflammatory bowel disease patients.
Okay, we have a couple more questions. One of them is there an association between a prior appendectomy and bloating, flatulence, belching? Is there a relationship between that and having had an appendectomy?
Not everyone. So yes, there are a subset of patients who had very complicated appendectomies. So maybe they had a perforated appendix, or they had a large abscess, or they went on undiagnosed a little longer. So they had to take longer antibiotics for their appendectomy. There are many factors. There are a few patients, they may have adhesions, surgical adhesions from having a more complicated surgery. The healing process was longer. They may form more scar tissue. Then, yes, those patients may experience more bloating and postoperative abdominal pain. They may linger on a little longer. But
Okay.
that's not true for everybody who undergoes appendectomy.
We have another question. Is extended use of PPIs harmful to your gut?
Excellent question. So I mentioned that in SIBO patients, small intestinal bacterial overgrowth patients, if you suppress the acid level too much, theoretically now, you can have some overgrowth of bacteria both in the stomach and as well as intestine. But as you know, stomach has acidic milieu, has a lot of acid in there. Hydrochloric acid is produced for digestion. So only a few bacteria is able to survive that environment. And one of them you guys already, I'm sure, know, Helicobacter pylori can survive in the stomach. Now, if you suppress the acid too much, then other bacteria theoretically can overgrow into the stomach and the intestine. And so You're right. Long-term PPI can have potential adverse effects. So the general rule is PPIs are generally safe medication. It's been around the market for more than 30 years. As far as we know, it doesn't cause cancer or anything. But if you take high doses too long, yes, you do need to be cautious about bone loss, right? Fractures, and so forth.
Okay. The other one is, what is the impact of artificial sugar? This person had their dentist talked about some causing in their mouth, some cause of effect of it, but is there a digestive issue with artificial sugar?
Yes, I think you're talking about like NutraSweet and
Yeah.
Splenda and things like that, right?
Exactly.
There's some data. I've been to some meetings, and some experts do feel that it may, if you ingest too much of it, you may ingest too much of it. I don't know the exact quantity of it, but if you ingest too much too long, it may alter the bacterial flora. It may have negative impact on your bacterial flora and then cause these symptoms that we described: bloating, gas, and IBS.
Her dentist told her that it was affecting the lining in her mouth, and she was wondering if it's doing much more than that.
Yeah, so obviously, the dental specialty is a little bit different than GI, but
Right.
if the artificial sweetener can have negative impact on our small bowel and bacterial flora, gut flora, I don't see why it wouldn't have a negative effect on your mouth flora.
Yeah,
It may. It can.
There's a few more questions, so I'm going to try to get to them quickly so we can get to them all. Under what conditions do you recommend an endoscopy? Excuse me, an endoscopy?
Excellent question. Excellent question. So one is what we call GI alarm symptoms. So alarm symptoms include bleeding. Okay, you have any signs of bleeding that persists. You bled once, but it hasn't happened again. I'm not sure that's a serious. But if you're seeing, I've seen a bleeding, I vomited some blood, I've seen some black stool, I've seen some red blood in my toilet paper, on and off, happens once or twice a week, but I've seen it for past 6 months. Oh, no, that's not normal. If you're seeing blood on a toilet paper, or you're vomiting a little bit of blood, even though it's not happening every single day for 6 months, that's not normal. So that's considered alarm symptom. Trouble swallowing, food doesn't go down very well, another alarm symptom. Weight loss, progressive weight loss, another alarm symptom. Someone's becoming anemic, blood counts dropping, but they don't have a good explanation why. They have no explanation why someone is anemic. Even if you have no symptoms at all, you're not bloated, you're not having pain, but they're becoming anemic. Another alarm symptom. They need to have an endoscopy done.
Okay. One other question was about Pepto-Bismol antacid. Is this PPIs? Is this included in that same group where you commented earlier?
Yeah, I mean, Pepto-Bismol, I think, do have some slight acid neutralizing effect. But as you know, Pepto-Bismol is taken in patients with diarrhea. So it has some binding effect. So it will control some of the diarrhea for you. It may even bind some of the pathogens or toxins in your stomach you may have ingested. So that's why when you travel to foreign countries and you happen to have a traveler's diarrhea, a lot of experts recommend you to take some Pepto-Bismol because it has some transient benefit effect. It's a binding effect. Yeah. But is it a very good acid suppressant like proton pump inhibitor? Will it have a long-term benefit in treating reflux or peptic ulcer disease, for example? No, it would not.
Okay. All right. And I had one other question. So I'm assuming from your description that when you have a regular colonoscopy, which all of us at our age just love having and really look forward to, that the test you talked about with the fluids and the bacteria are not done in a routine colonoscopy. They're just doing a viewing. Is that correct?
Excellent question. So, I mean, obviously, colorectal cancer screening modalities guideline is a whole talk of its own, right? I would need a 30 minutes to do it. But if I summarize for you in 1 minute or half a minute, is What's currently FDA approved is the Cologuard test. So Cologuard test is pretty good. The problem with the Cologuard test, and the microbiome test is not approved yet, so we can't use those. You know, there is the Hemocal test where they test for blood. They're not testing for DNA mutation. They're just testing for a little drop of blood detected in the stool, okay? Or there's a fecal immunoglobulin test, which is also kind of a blood checking for blood in the stool. Those three are approved, non-invasive, non-colonoscopic approved screening tests. The problem with the Cologuard test is it has a high false negative rate, okay? So 30 to 40% of patients who may have significant precancerous growth or polyp in their colon may still have a negative test. Okay, so it's not a bad test, and I recommend it to my patients to get it done every 3 years if it's offered through their primary care doctor's office. The problem is then they skip their screening colonoscopy. They don't do their 10-year. You're supposed to have one done every 10 years starting at age 45, right? That's the current guideline. By the way, the last colonoscopy the person is supposed to have has also been extended. Okay, it used to be about 75 in the old guideline, like 15 years ago. Recently, they changed that to between 80 to 85. Why do you think they did that? Because more and more people are living up to 90s, much more percentage-wise than any specialty societies have ever expected. So they're falling behind in their guideline. That's what happened with the age 45, is that they knew that people were developing colon cancer in their early 40s. They knew that. They knew about that in 20, 30 years ago. The reason why they couldn't change the guideline from 50 to 40 was because they didn't have the resources to do so. You can change the guideline, but so what? You know, if you don't have enough doctors, you don't have enough endoscopy suites, you don't have enough hospitals, you don't have enough nurses, you don't have enough technicians to help you to bring all those patients in to do the screening, then changing the guideline doesn't make any sense. So finally, they upgraded the infrastructure and the resources got better. So they now changed the age to 45. Is 45 good enough? No, it's not. We're still seeing, unfortunately, patients in their early 40s developing colon cancer. So those patients, I'm not saying we ignore them. We take a careful history and we listen to them and say, if a 40-year-old person comes in and says, doctor, I don't feel good, I'm losing weight, I'm seeing some blood in my toilet paper, then I bring them in. I bring them in and do an earlier colonoscopy on them, you see. But I'm talking about the routine screening test. The age has changed to 45, finally, just a few years ago. And now they're changing the guideline. Instead of stopping the colonoscopy at age 75, we're extending up to 85, as long as they're healthy enough to accommodate the sedation and the colonoscopy.
Okay. I'm afraid we're going to have to cut it off. We have our time is up, and I promised the doctor, you know, we would just hold to that time. So I really appreciate everybody's attention. As I said earlier, there's a lot of information here. I will be sending out the PowerPoint along with the link so that you can look at those slides and the terminology and get more information, you know, at a slower rate, at whatever rate you want to read those. So that'll be going out. So I'd like to thank Dr. Kim. Really appreciate all the information and your time this evening. And as always, thank Allison Combs for her setting up this entire program. And thank all of you for joining us tonight. It's kind of time to head out. Hopefully, many of you will be there tomorrow for our Before You Check Out program, which is also going to be done with members of LMH Health on advanced directives, which is very important. So hopefully I'll see many of you there tomorrow morning. Have a wonderful evening, and thank you for attending, and we'll see you at the next retroactive event. Good night.
Thank you very much. Thank you.